Without further ado, I'll hand it over to the Badia team. The chat is open, so please feel free to put in your comments and suggestions. All right, over
Yes,
to you,
sir.
Shashank. Yeah.
Yes, sir. Good evening, everyone. So this is a 7-year-old boy who is otherwise normal child, other than some vision issues since early childhood, but otherwise normal birth history. He only had issues in distant vision. Otherwise, he's able to see blackboard and is able to read. Everything is fine and developmentally normal child. So he presented with. He came to us first time in October 2024 with multiple episodes of left focal seizures involving left upper limb and left lower limb. So he had multiple episodes of seizure. Gradually, he developed left hemiparesis involving, then had left UMN facial palsy. So also had encephalopathy from the day 2, day 3 of illness. So thought something like encephalitis or something. We did imaging and then we went on to do CSF. CSF showed pleocytosis, 52%, 52 WBC, which is lymphocyte predominant, and protein of 44, sugar is 55, and lactate is 3. So BioFire had HSV1. So I would like to show the imaging.
Yeah. So this is the initial imaging, I think, done in October 14th.
24.
24, yeah. Any prior neonatal or infantile, early infantile imaging, or this is the first time?
No, sir, nothing significant in the
Okay.
birth actually.
All right. So, okay. On the imaging, I think we have selected images of the main findings out here. If we
Yes.
concentrate on the diffusion ADC, you can appreciate these multifocal and confluent abnormalities, particularly on the perisylvian regions, temporal lobes, occipital lobes, and also involving the corpus callosum. Some cystic areas of along the subcortical cortical regions in the bilateral occipital regions. Contrast enhancement, I think there is some enhancement out here in the perisylvian region and the right temporal lobe going up to the occipital lobe. So these were the main findings. So multifocal, partially confluent abnormalities with cystic degeneration along the posterior aspects with some degree of plephalangeal enhancement out there, and these multifocal areas of diffusion changes on the initial scan. So based on that, I think as Rajikant has mentioned, they had gone out right with the CSF.
Yes, sir. So CSF had pleocytosis and HSV1 was detected. So
Yeah.
we started child on IV acyclovir as well as anti-edema measures. Even after that, fever persisted and sensorium worsened. Also developed right gaze palsy, and gradually child initially had only left focal seizures. So gradually started developing left upper limb EPC. So epilepsia partialis continua. So we titrated ASM. We did repeat CSF after around 8 to 10 days, which showed 83 WBC lymph predominant and protein of 103, slightly elevated protein compared to previous one, and sugar is 55. Again, CSF HSV PCR sent, which came negative. So we did repeat scan, which showed actually progression of the disease. I have not added that repeat scan, which new onset restricted diffusion was also there. So as child is not responding to acyclovir, we started IV foscarnet. So we have given IV foscarnet along with DEXA cover we have given. So for 14 days IV foscarnet, 21 days of acyclovir with DEXA cover we have given. So child showed clinically improved, and even MR. Can you show the next slide? So child gradually became symptom-free with improvement in left hemiparesis and left facial palsy. EPC resolved, and child discharged after around 1.5 months of hospital stay. And at 1 month follow-up, child sensorium is completely normal, having occasional, one to two seizure per every 10 to 15 days, left focal seizures. Otherwise, child is doing well, and even hemiparesis improving. So we did a repeat MRI after 4 to 5 months into the illness in April 2025. So this is the repeat imaging.
Well, repeat image again, you can appreciate cystic changes slightly progressed going up to the temporal lobes, and also the multifocal abnormalities are now more confluent. You can appreciate the progression in terms of imaging. I don't have diffusion ADC to see if there are any acute lesions, but yeah, as compared to the initial scan, there is some degree of progression, some chronic changes in terms of gliosis and sublunasia, especially in the right hemisphere, with these posterior hemispheric cystic changes. So imaging wise, if we skip the interval scan, there is progression compared to the first scan in terms of the areas of involvement.
Child actually clinically improved.
Yeah.
Again,
Yeah, sorry,
the progression you are saying in terms of
the extent
disease
of involvement,
progression, or is it the gliosis, which is whether it is recovering part and then there is healing with gliosis?
Yeah, we don't have the in between scan. Yeah, if you compare to that, this first scan, these areas are not involved. So there must have been some area of involvement in between, which is now turning into the chronic changes.
So at this time, we may consider it as a sequelae
And
of
the
whatever had
left,
happened.
yeah, and whatever, and the left side was not there on the first scan. I don't have the scan done up
Intermediate
to the
scan.
intermediate scan, but if you see on the scan, you see the left the left aspect of the periventricular white matter is not involved. Whereas over here, if we consider this as chronic, also there was some degree of involvement in between, which is now
Okay.
going into
So
gliosis.
by this time, child had come to his premorbid state. He was absolutely fine, seizure free. Mild deficit was there, but he was otherwise
Doing well.
premorbid.
So now again in July 2025, he presented with headache and vomiting for 1 to 2 weeks, followed by multiple episodes of left focal seizures involving left upper limb after the 1 week of onset of headache and vomiting, and also had right deviation of angle of mouth, which is new onset, and fundus showed bilateral papilla edema. So repeated CSF doesn't show any pleocytosis, but protein is elevated 133 and biofire is negative. So we went ahead with again neuroimaging.
So we first did a neuroimaging, and after long time we did a CSF.
Yes.
Okay, so neuroimaging, now you can appreciate definite progression. There is some mass effect also on the at basal ganglia, thalamus, mild midline shift, some areas of gyral enhancement, which will be better appreciated on the next slide. But as you can see, there are some areas of abnormalities out there in the right side, which was not seen on the previous study. The cystic changes remain the same, but in terms of areas of involvement, there is definite progression. Also, you can appreciate it's going up to the subcortical white matter in the temporal lobes, previously only up to the periventricular regions. So disease progression, I would say, is there with some mass effect on the right hemisphere.
What
And
type of pathology you are considering in this
yes, I'll come to
progression?
that. So yeah, I'll come to that. Post contrast, again, you can appreciate the abnormal enhancement, the diffuse gyriform enhancement, as we have seen on the right hemisphere. Based on these imaging, also some degree of enhancement in the left posterior hemisphere. Based on these imaging, I think imaging differentials, we have Dr. Gopinathan who has shared his cases. I thought it kind of fits into chronic granulomatous herpes encephalitis, which has this diffuse, extensive involvement can be seen. This gyriform enhancement is usually seen in changes with HSV encephalitis. Some of them can have other underlying conditions, as this case had hyper-IgM syndrome. I found also a pathological letter, no imaging, but they also described cystic changes and encephalomalacia in chronic granulomatous encephalitis. So in terms of imaging, I think that is one of the primary differentials we're thinking of. Gopi, you want to add anything?
Sir, I have one question here.
Tell me, sir.
Yeah.
Okay.
Yeah, Gopi.
Sir,
Yeah, sorry.
So in the first scan, there is a restricted diffusion in the areas involved, and the current scan doesn't show that restricted diffusion.
Yeah,
So
that is okay. Based on time of involvement, and there must be ischemia at that point of time or activation at that point of time.
okay.
So even in the first scan, there's mixed pattern of diffusion. No? There are some areas vasogenic, and so it's not completely cytotoxic.
Yes.
See, the posterior cysts are not explainable by the
Chronic
cysts which are there,
changes.
posterior parieto-occipital cysts.
Yeah.
So those cannot be explained, and they are constant.
I'm telling you the posterior cyst, that is the telltale evidence of previous HSV infection. Okay. So we have 3 cases. I think 3 cases having more than 10 years. We have the follow up the patient, and this is the first patient. This is the first patient. What we have the presented here, we can see the gyriform enhancement. It's everything started after 1.5 year only. So the same kind of presentation, the hemiparesis, and the facial palsy will be the presentation, not a kind of any other mass effect lesions. And the thing is, when you do, we had did previously, we don't need the biopsy. Only HSV is CSF positive is there, but we did the biopsies. biopsies shows there is a live HSC antigen is there in the specimen. So, we think, and also there is a granulomatous changes, chronic granulomatous. So we came to the diagnosis of chronic granulomatous herpetic meningoencephalitis in this case, and we subsequently we followed for the immunodeficiency status. One case happened to be the hyper IgM syndrome, other case happened to be a DJAR syndrome. So the main crux is, so whenever we see this kind of HSV patient turning into the chronic herpetic meningoencephalitis, you have to rule out immunodeficiency syndrome first. Second thing, these patients is more than 10 years they are in follow-up, and in between they are continuously with the acyclovir and whenever there is symptoms, they are presented with the steroid anti-inflammatory drugs we have given, and still they are on the anti-seizure. And also, since the HSV is still positive there, we are giving the acyclovir more than 5 years on patients. So that is how this disease goes. The only thing is, we are recognizing this kind of lesion, the gyriform enhancement with the mass effect, and some cases will be the midline shift. And if gyriform enhancement still that, we are still having the herpetic antigen, HSV antigen in the brain.
So you are
So all
treating
of
them with
one question. Their CSFs were routinely normal, no cells and no HSV. Only the herpes antigen was seen in the brain, or because you see herpes. No, the first CSF may have shown it, but subsequent CSFs in the relapses, did they show HSV PCR positive, or they were negative? And was there
The
any
PCR is negative.
cytosis?
Second time PCR is negative. That's why we did the brain biopsy and confirmed the HSV.
And even there was no pleocytosis.
Pleocytosis is there, but we haven't confirmed the HSV on the PCR itself. That is why we did biopsy and confirmed the HSV antigen.
I see.
So HSV antigen was confirmed by PCR in the biopsy.
Yes.
And you are giving them acyclovir for 5 years?
Yes. And acyclovir is continuing. We are continuing the acyclovir. In between, patient is normal. And there is some exacerbation. That time patient admitted in the ICU, and all the anti-edema measure is with the somewhat is reduced, and patient go home. It is a continuous story since it's a immunodeficiency syndrome. So we cannot have a complete cure in this case.
Okay.
In this case also, it's a kind of T cell abnormality. There is some abnormality in this case.
Yeah, so that was on steroids. So we exactly don't know. This LSSA is after the steroids.
Okay.
And there was some this we also did a whole exome which showed this LIG4 syndrome, but it is not.
It is
heterozygous it's not
and
correlating.
recessive.
Yeah.
Okay.
It's not correlating.
Yes, basically it had pancytopenia, developmental delay, some dysmorphic features, and some skin rash also. So it is not clinically fitting into that whole exome LIG4.
So day before yesterday, we have biopsied the thing, and the surgeon said that it is very means he felt that it's very granulomatous and calcific thing. So we have sent it to NIMHANS, and we are awaiting the biopsy.
Yes, also our case also it's confirmed with NIMHANS, and they did the HSV antigen, the PCR, the tissue. I just asked them to do the stain specifically to confirm the HSV presence.
Yeah. So that's what I mean. Those granulomatous things which were seen, but to give acyclovir for 5 years, protecting the kidney is difficult, right?
But since there is a live disease there is our clinician thought we have to continue the acyclovir unless there is a contraindication or a complication occurs.
Dr. Udani, you had a case in 2000, Anuj Joshi, who was like Foscarnet, for which Foscarnet was given.
Yes, but we did not have these kind of changes on MRI.
No, he didn't have these changes, I know.
And it was a relapsed one, so I'm not sure it was an NMDAR or something of that, some autoimmune stuff, because at that time, of course, in 2000, there was no idea that there was something called autoimmune
My
encephalitis.
case, both cases, NMDR is negative.
No, I'm sure it is. I'm just
Yes,
saying
yes.
in the MRI, and the picture also is the MRI picture
Totally
is
different.
not, yeah, totally different from NMDR encephalitis. So I agree with you. This may be some chronic. We had a patient recently who had, uh, you know, a progressive bilateral sylvian atrophy. First, it was on the left, then on the right, perisylvian atrophy. It was thought to be first Rasmussen's and all that. And we were wondering whether that's a chronic hepatic encephalitis, because sometimes you have a chronic presentation of a herpes encephalitis which goes on for a much longer time than the usual HSV. But this is, of course, different because you're saying it's a relapsing condition which comes every few months or years or whatever.
Yes, yes, yes. My case is more than 10 years. So comes and goes, same kind of presentation. So mass effect will be there. After giving steroids and everything will be reduced. The patient go home for normal for 1 or 2 years. Then we'll come to the ICU admissions. But in between, we have continued the cyclovir with the anti-seizure medication.
Very interesting. Thank you.
And the
We'll
main
give you
difference
a
is
follow-up after biopsy comes.
yes, yes, definitely. About we since based on our 3 cases, so we published in the journal, and it tells that if you see this kind of chronic granulomatous herpetitis meningoencephalitis, most likely immunodeficiency T cell problem will be there, or else other immunodeficiency syndrome will be there. For that, our conclusion is we finish it like that.
Sir, one small question. For every time the child gets admitted, how long steroids
Like kind
are
of
you giving, sir?
hemiparesis or a facial palsy, like that only presentation.
I mean, how long are you giving steroids whenever they come with the worsening
I
or
think
relapse?
15, I think a hospital ICU admission at least for 10 days that time, after which taper the dose and everything. Every on that kind of episode, it will take about at least 15 days.
Okay, sir.
Okay.
Yeah.
So we don't find any classical treatment for these conditions, and trial and error only we are treating.
Yes.
Yeah. Thanks, Gopi. Any
Okay,
other
okay,
comments?
okay, thanks.
Thank you. Thank you, Gopi.
Thank you, sir.
Just to confirm, it's not confirmed diagnosis, but you're thinking in terms of HSV. If anyone has any other suggestions?
Okay.
Yeah. All right. Thanks, Gopi. We'll wait for the biopsy reports and hope you can enlighten us, Rajikant and Dr. Shifa.
We'll update once biopsy report
Yeah.
comes.
All right.
Yes.
Thank you.
Yeah, we'll
Yes.
update.
Thank you, sir.
All right. Nikesh, if you're there, over to you.
Yes, sir. Can you hear me, sir?
Yes, yes, please go ahead.
So this is 7 years, 7-month-old male child born out of non-consanguineous marriage with no significant antenatal perinatal history with normal development. So this is the his course of event. In May 25, child has history of varicella infection. On June 6, fever for 2 days. He has taken antibiotics as oral antibiotics at a nearby hospital. The fever got settled. On June 10, child again started having fever, moderate grade, intermittent nature. On June 13, the fever spikes were intensity was also increased, as well as the pattern become continuous, along with mild hepatosplenomegaly. So they went to the same hospital again. Investigations were like HB hemoglobin level was 8, WBC count was 17,000, mainly lymphocytes. Platelet count was 70,000. So the child was started with ceftriaxone, doxycycline, and Falsigo. On June 17, as the fever was not settling down, another investigations were done. Ferritin was 751, fibrinogen levels were 97, triglyceride levels were 619. So possibility of HLH was considered, and child was started with meropenem injection and injection methylprednisolone. It was given for 4 days. The fever got settled and child was discharged. Next month, child was normal. Again, after 1 month, 18 July, fever restarted. Child was admitted again for the same. On 25th July, child was again having fever episodes. At that time, CBC was showing HB 7.8, WBC count decreased 4,800. Platelets were around same 82,600. On day 5 of admission, there was no fever and platelets were increased to like 30,000. At that time, child was referred for hematology review. So say on 2nd August, bone marrow aspiration with biopsy was done. That was normal. But the child was having a new complaint in the form of headache, mainly in the frontal occipital region, along with vomiting episodes. So on 6th August, in the view of headache, child was done with MRI brain, which showed cerebellar edema with periventricular ooze. ANA profile was done, which was negative. CBC again done, was negative. Ferritin, triglyceride, fibrinogen levels were done. That were normal. So child was started with tablet Diamox and tablet Visolon. On 6th, from 6th August to 26th August, child was at home only. He was having intermittent episodes of headache, mainly in the occipital region. On the 26th August, child was having severe occipital headache along with right-sided torticollis for 2 days. So he was admitted at Rainbow Hospital and MRI brain done again.
All right. So MRI brain, I don't have the initial MRI. We'll go with Nikesh's word of cerebellar edema with possible hydrocephalus. So on the 26th setting, 20 days later, you can again appreciate there is cerebellar edema, some degree of ascending transcendental herniation resulting in obstructive hydrocephalus, periventricular interstitial edema out there. Diffusion changes, there was mild restrictive diffusion, some predominantly vasogenic in nature. I'm not putting the ADCs, but only a few of them show reversal. And you can also appreciate there is inferior tonsillar herniation and hydrocephalus causing bowing or thinning of the corpus callosum. So main findings are cerebellar edema on both sides, resulting in obstructive hydrocephalus with GRE1 deformity. No hemorrhagic foci or calcifications on the SWA sequences. Post contrast could not appreciate a significant enhancement, even in the cerebellum or the supratentorial brain. So imaging wise, given the acute presentation and also the follow-up scan, we're going with cereballitis. As you know, cereballitis is the causes are, there can be multiple causes. So at least imaging wise, we can say that it is cereballitis. Can we differentiate from an infective or immune condition? Possibly. This paper, I think Dr. Baltazar is there on it. What they found was the immune-mediated causes had cereballitis along with supratentorial changes with, and the infective ones had predominantly cerebellar edematous changes. So imaging-wise, I think it's pretty non-specific. We are going with cereballitis, no changes of HLH, typical HLH in terms of microhemorrhages or enhancement pattern, especially in the posterior fossa. So I think, yeah, the imaging diagnosis, we're going with cereballitis, and then I think the child had further follow-up.
So child was admitted on 26th August and 27th August morning, child was having a seizure episode in the form of rolling of eyeballs along with posturing episodes. So we thought of raised ICT and pediatric neurosurgeon opinion was taken and emergency posterior fossa decompression was done with right Ommaya reservoir placement and continuous Ommaya drain was placed. In that with passive drainage 24 within 24 hours 600 ml drainage is came. Along with that, right cerebellar tissue biopsy was sent for microbiology and histopathological examination. The CSF examination routine analysis was protein was 10, glucose level was 86, and there were no cells. From 28 to 31st August, child improved gradually in sensorium part. Drain output was decreased gradually, so it was removed after 48 hours. After removal of the drain, child was having intermittent brief episodes of bradypnea with along with bradycardia. So Ommaya tapping was done on next day, and the child eventually gradually settled and shifted to the ward. On 1st September, child was fully conscious oriented. So at that time, whole exome sequencing was done, was sent to rule out the primary HLH, and child was discharged. So these were the investigation that we have done during the Rainbow hospital stay. CBC was done 4 times, it was normal. Ferritin levels were also normal. LF, TRF, electrolytes, all other investigations were normal. ESR was 52. CSF malignant cytology report was sent. It is normal. Tissue culture report just came today. It is showing like histio mature dense infiltration by histiocytes, mature lymphocytes, along with few plasma cells along the leptomeningeal surface. And histiocytes have abundant eosinophilic granular cytoplasm, with few of them showing nuclear debris. So it is mainly suggestive of lymphohistiocytic disorder, unlikely to be LCH or non-LCH histocytosis. So we are just awaiting for that whole exome sequencing report.
Okay. The question here, Nikesh, does the imaging correlate with HLH? Is that the question? Or any other question we have?
Hello.
Yeah, Nikesh. Yeah, again,
Yes,
sorry.
so our main question was whether it is due to that varicella that had occurred in the May. It can be due to any other infection, post-infection, secondary HLH, or it is primary HLH that we are dealing with.
Yeah,
Because,
and Dr. Ramya here. We also want
Yeah.
to know if others have any experience of such kind of cerebralitis causing edema and then all these things. This child had multiple fevers though, but then initially thought of HLH, then suddenly presented with all were systemic complaints, and suddenly he started having headache.
Can
All
I
right, yes.
briefly comment? As
Yes, I can.
Nihaal said, this is the imaging pattern of a cerebellitis with secondary hydrocephalus. This is absolutely non-specific. It can be found in many etiologies or sometimes idiopathic or corona or whatever. And as varicella is high on the list as a causative agent, I wonder whether this is not the most likely explanation. I agree the cause is somehow unusual because most patients recover without any particular problems. But what you have seen secondarily in terms of hypertension, hydrocephalus, this is all non-specific and a cause of the mechanical obstruction.
Yeah, thanks again. I agree. The imaging wise, it doesn't. I mean, I wouldn't point out as HLH if that is the main question.
Yeah, our one more doubt is whether varicella, which was there like a couple of months ago, like 3-4 months ago, will it have presentation like this? So
There are some chronic ischemic foci. So at least see one here over here, maybe one over here in the perisylvian cortex.
yeah,
And the
in
white
that
matter also. Yeah.
left
But-
side also there.
Okay.
There, posterior putamen. Yeah.
But
Yeah.
this patient had varicella not months
2
ago, but I think 2 weeks ago, no? Or 3 weeks ago.
It
No.
starts from
It is in
May again,
the-
and
May.
yeah,
Almost
May.
3
So-
months ago.
so 3 months ago. Yeah.
Okay.
So that I think can explain varicella. But cerebralitis, I'm not sure if would have gone directly with HLH, at least imaging wise. HLH will be, I mean, down on the differential, if that's the main question. Only on imaging.
Okay, sure.
Yeah.
Yeah. Thank you.
Just to highlight, these are the main findings of HLH, which our child does not have yet, at least. These nodular multifocal areas of enhancement, especially in the posterior fossa. So that is lacking to call it HLH on imaging it. All right. If there are no further comments to our next case, Sarika,
Yes.
over to you.
So we present. This is a 1 year old, 1 year 11 months old girl child born to non-consanguineous marriage, second in birth order with no perinatal issues and normal development till this pre-morbid stage. With history of like elder sibling being known case of nephrotic syndrome with 5 relapses. This child, our index child, is also diagnosed as steroid-resistant nephrotic syndrome 6 months ago at around 1.5 years of age, and being steroid-resistant, child was also given cyclophosphamide. Now she presented with fever, vomitings, and dull activity. On day 2 of illness, child had 1 episode of seizures, like generalized tonic seizures, but not associated with fever. That was managed at local hospital and referred to our hospital. At our hospital, child was in decompensated shock with poor respiratory effort. So child was started on mechanical ventilation and inotropes. At that time, 2 echo was done. That was suggestive of cardiac dysfunction. And during the course of hospital stay, child had persistent fevers and persistent encephalopathy and hypertension requiring antihypertensives. And child had AKI, so child was on dialysis also. When we examined, child was on morphine sedation, but there was spontaneous eye opening, only minimal extension response to pain, and pupils were 2 mm sluggish reacting to light. Doll's eye was present and cough reflex was present. In view of this persistent encephalopathy and background issue of hypertension and steroid-resistant nephrotic syndrome, imaging was done.
All right. The imaging done last week. You can appreciate these multifocal confluent changes of restricted diffusion in the frontal white matter going up to the parietal white matter. Also, if some areas of involvement of the basal ganglia, we have this focal abnormalities. So predominant finding in the frontal white matter, periventricular white matter, the basal ganglia. Some abnormalities in the right cerebral peduncle out there in the temporal lobe, and also involving the posterior fossa. Bilateral hemispheres demonstrate these areas of multifocal areas of restricted diffusion. If you see on the ADC sequences, the supratentorial white matter changes show complete reversal, whereas the cerebellar, not all of them demonstrate complete reversal on the ADC sequences. So it's a mixed pattern with T2 shine through on the, especially in the cerebellar regions. Here you can appreciate the extent of the lesions. Again, you have the multifocal abnormalities, subcortical, cortical regions involving the deep cerebral white matter, the basal ganglia on both sides, and also posterior fossa involvement, as mentioned. No areas of hemorrhage or calcification on the vestibular sequences. This is a T2 SAS just to highlight this reduction in the volume of the supratentorial and the vermis out there. MRV was done and there was no areas of thrombosis or stenosis.
So we have evaluated this child because this child was having persistent fevers and also encephalopathy. So to rule out sepsis, CSF analysis was also done. That was suggestive of like protein and glucose being normal and no cells. And the EEG was suggestive of like diffuse background slowing with no sleep markers and IEDs. And urine culture was showing Trichosporon asahi. This is one of the pathogenic Trichosporon species organism. And renal biopsy was done before this admission. That was suggestive of query minimal change disease or FSGS. No proper report was given. And tracheal culture was also showing Pseudomonas that was carbapenem resistant, and appropriate antibiotics were added. And child was extubated 3 days ago, but child is requiring persistent minimal oxygen support and still persistent encephalopathy. Though child is opening eyes spontaneously, no recognition of parents, no fixing or tracking. And we also noted there are no peripheral limb movements even along the gravity also. But we could not do repeat imaging because of this requirement of oxygen support. So,
So I think, yeah.
So our
So main-
question is whether these changes are due to hypertension related, like press related, or infection related.
Yeah, and one more, this child also had septic shock. So watershed infarcts were also
Yeah.
one thing we were considering. Yeah.
So I thought, at least on imaging, I thought maybe not a single cause infection with sepsis and the posterior changes pertaining to press. The conclusion I thought was multifactorial, but yeah, the case is open if anyone has any suggestions. First question is, do all the changes explain a single cause can explain all the changes, or is it a combination of sepsis, infection, hypertension, or kidney-related, breast-related changes?
One more doubt we had was whether this periventricular, those nodular kinds are there, right? On the diffusion restriction.
Yeah, they must. Yeah, sorry.
Yeah, those usually the watershed will not have periventricular. They are little not
Yeah,
along the ventricle. So yeah, that's why
but they can
probably.
be, that can be there, but these can be just other ischemic foci, vasculitic
Which
related
one?
changes.
Okay.
Small vessel vasculitis related changes. Watershed is a different entity, but these deep raise the basic ganglia changes and these changes can be small vessel ischemia related causes secondary to an infection.
Okay. Okay. Sure. Yeah.
Let's see. Danny says press or vasculitic.
So do we see vasculitic changes in this periventricular region also usually?
In terms of infection, it can be seen anywhere. Any of the small vessels which are involved can have these changes.
Okay. Now my point is, if these periventricular, are they of any significant or will they point out to some etiology?
I mean, typically the pattern we have seen was rickettsia having the starry sky pattern.
Okay.
But any hematologically carried infections or viremia can cause those similar changes.
Okay.
But the most classical one is rickettsia, but I think any infection causing vasculitis can cause. The starry sky pattern is what we usually term on radiology.
Okay. Yeah, thank
you. I'm sorry, I missed.
Sorry.
What was the finding in the kidney biopsy?
Sir, they like official report we haven't seen, but it was documented as query minimal change disease or FSGS type.
Okay, no, I was just thinking if there's anything vasculitic involving both the kidney and the brain, small vessel vasculitis. So minimal change, of course, will not explain. And
only loss of podocytes. Yeah.
And elder sibling also had nephrotic syndrome with 5 relapses. So this child is also having nephrotic syndrome, steroid-resistant nephrotic syndrome. So genetics was sent for this child, but it participated.
So we're thinking vasculitis and press as a combined cause, infective vasculitis, most imaging possibility. The cerebellum can have, press can be seen in cerebellum also, so I wouldn't rule that out as a press manifestation. Any other comments? Okay. So to conclude, we're thinking vasculitis and possible press-related changes causing the imaging findings. Harika, anything else regarding this case?
So this child is given IV methylprednisolone.
Okay.
So if it is like a vasculitis, usually it responds to steroids. But still, like sensorium is no much improvement.
When you say vasculitis, you mean what exactly? You mean immune vasculitis, or you mean infection-related vasculitis like you get in, what exactly do you mean by vasculitis? This is a very non-specific term because that actually pathologically means you actually see inflammation around the vessels.
Yeah. In terms of imaging wise, Dr. Rani, yeah, I will just say small vessel vasculitis cause infection in
Only in the
immune.
brain. Only in
Yeah,
the
in the
brain,
brain,
right?
in the brain. Yeah, in the brain. The cause of that, I think, is beyond radiology at least. I think labs and biopsy will be helpful. But in terms of the systemic one, yeah, I'm not sure.
No, in the sense your biopsies in the kidneys and all doesn't show any vasculitis. There's no other, like skin lesions or anything to suggest a systemic vasculitis. You have a kidney problem. If it's a vasculitis, you'll probably think that's a vasculitis of the kidney causing the hypertension and the renal failure. But over here, that is not the case.
Okay, but the child also had some infection. I mean, would the infection cause changes? I think secondary infections as a child has Trichosporon, Pseudomonas, So
Just
infective vasculitis.
to
Yeah,
add one
Dr.
more.
Abhishek.
Just to add, this child also had a small purpuric lesion on the right side of the foot. Clinical, when we examined, I'm not sure this point was put in this. So likely there's something else going on, like apart from the brain, even systemic vasculitis possibility, because he had a small purpuric lesion on the foot.
Maybe you should do a biopsy and just find out
Yeah.
of the foot.
Okay, sir.
That thing still there.
Jayant, is there the possibility of HLH? The lab supported, Harika?
The ferritin was only 16, sir, not elevated. And only anemia was there, no thrombocytopenia or leukocytopenia. And
Scrub typhus, I would agree. We can see other causes. Fabricia, no, we didn't do any MRA or vessel volumetric.
If I can just add a point, this child has a known kidney disease. I was just wondering whether the IgA and other profiles would play a role in sort of causing stasis and then vasculitic changes, and whether that would help the IgA status.
ma'am, like because biopsy was showing like MCD or FSGS, they have not done IgA levels.
IgA nephropathy, right?
Yes, sir.
Okay, I have nothing else to add. I think there are no other in the chat. So maybe we can biopsy the foot lesion and check and
Okay, sir.
Harika can just discuss. Yeah. But imaging wise, it's pretty non-specific, I would say. In terms of the organism or the cause. But there are multiple foci of ischemia in the supraendothelial vein.
So like we should consider like multifactorial cause.
Yeah, possibly. The risk factors are many, no? In child. Kidney issues, hypertension, then secondary infections during the stay, and extubated.
Yes, sir.
Okay, if there are no suggestions, I'll move on to the next case. Dr. Prerna or Vishal, you're there. Over to you.
Good evening, sir.
Good evening.
So this is regarding 5-month-old boy, second issue of non-consanguineous marriage, was vaccinated up to 10 weeks of by national immunization schedule, and he developed viral cold cough fever at home, and eventually within 4 or 5 days, there was bilateral lower lobe involvement, and there was a decrease in sensorium within 5 days, and he was managed at home only by the local pediatrician. And while on day of illness 5, he was resident to our hospital with 2 GTCS 12 hours apart. When we received the kid in the casualty, the child was lethargic. There was tachycardia, tachypnea, saturation was 88% on room air. And because of the low GCS, we was intubated. Child had anosocoria. Right sided was 5 mm and left sided was 4 mm. Was sluggishly reactive, and anterior and frontal was full. DTR were brisk, and this today's a day of illness 10. So in this 5 days illness, 5 days illness, child like we have done his CSF and routine investigation, and CBC suggested of 8.8 HB and total count of 3,800, and it was a microcytic hypochronic anemia. Electrolytes were normal, coagulation.
Akshay, just stop you. Will go to the images and come to the labs. That's fine.
Sorry, sir.
We'll go through the images and then come to the labs if that's okay.
Sure, sir.
Yeah,
Sure,
so I
sure.
think just to summarize, basically this was a well-thriving boy, fully vaccinated, just the 16 weeks vaccination missing, and then had a very rapid deterioration following a minor upper respiratory tract illness with RDS type picture, respiratory distress, and altered sensorium, and features of raised ICP.
All right. With that background, I think there are two scans, a CT and an MRI. This is the CT done, I think, a couple of days prior to the MRI. You can appreciate there is widening of the extracorporeal spaces in the frontal regions. Some effacement of the sulcal spaces, possibly indicating some degree of edema, but I think the MRI will be more helpful. But no midline shift marsh effect at this point of time on the non-contrast plain CT. Yeah, possibly, so you can appreciate that it's not completely hypodense. There is something going on in the extracorporeal spaces. But we'll go on to the MRI for better clarity. 2 days later, this is the MRI. You can appreciate confluent and multifocal areas of restricted diffusion involving the bilateral hemispheres, subcortical cortical regions, also involving the periventricular regions, centrum veil, the deep brain nuclear structures, the brainstem, and also the cerebellum. And you can appreciate on the ADC sequences, there's a confluent abnormalities involving the peripheral regions and multifocal abnormalities involving the central structures, that is the deep brain nuclear structures, corpus callosum, brainstem, and the cerebellum. On flare sequences, these are non-contrast flare sequences, and you can appreciate the CSF is not clear. There is something going on in the CSF spaces in the frontal convexities on both sides. You can appreciate the extent of edema on the flare sequences. It's a mixed pattern of edema, as we have seen on the diffusion ADC sequences, involving the supra and infratemporal brain. And you can also appreciate the vessels out there. They are slightly hyperintense, possibly some degree of inflammation, infection going on there, though this is a non-contrast scan. On the SWS sequences, do not appreciate any areas of significant areas of blooming or hemorrhage within the parenchyma or extraaxial regions. This is the angiography of the brain, and you can appreciate there is a beaded appearance of the areas of the vessels of the circle of Willis, the MCAs, ACAs, and also the terminal ICAs, and the peripheral branches of the MCAs also demonstrate irregularity out there. Based on these findings, I think we're thinking of infective causes causing ischemia and also causing the extraaxial changes with possible meningitis and vasculitis as the imaging possibility. I think after that, labs were done.
We went for an CBC. It showed an viral picture. Total counts were 3,800, and the coagulation profile acts were normal and slightly raised. Like PT-INR was 1.99, and we have given the vitamin correction for same, and EEG showed moderate to severe encephalopathy. CSF has showed pyogenic meningitis picture. Total counts was 5 and 58 with a neutrophilic predominant, and protein was 289. Where glucose was 39 and BSL was like 110. And gram strain showed a gram positive cocci, and ZN strain was negative. So, sir, can you just next slide, sir?
So only slide.
Yeah. So we were thinking this could be a pyogenic meningitis, and this could be some. Yeah. So we were thinking.
So just Akshay, I'll just stop you there. So actually, we had seen the CT and our post MRI during the discussion. The initial report of the MRI was reported as global hypoxic insult. And then after that, they said that the picture was more in fitting with viral encephalitis, even though we had a very frank, clear-cut picture on the CSF of pyogenic meningitis. And they had started steroids on this child, which was quite dangerous with such high CSF neutrophilic count. So my question was that would any of the viral, so this child presented with a simple upper respiratory tract illness. So could it be a dual pathology that the child has maybe something like RSV with a super added bacterial infection that caused the changes, or is it just very classical?
All right. At least imaging wise, that's streptococcus for you, and it looks pretty identical to our case. But yeah, the case is open if there's a possibility of viral and a bacterial infection.
Has the fever settled?
So the fever
Yes.
has settled, but the child's overall sensorium and other things hasn't changed. The child is not doing very well. Intermittent ICP spikes are still there, which they're draining intermittently.
No, because you get this post-pneumococcal meningitis, you get a vasculitis. And I think
Yes, sir.
that actually
So
responds
I
to
think the CSF came in later after the imaging. Once we had the CSF, just putting everything together, it looks pretty much like pneumococcal. But this child has received a vaccination up to 10 weeks of age. So I'm just thinking whether there could be some immunodeficiency underlying.
The vaccination does not cover all serotypes, does it?
So at least the 13 most prevalent.
13.
Yes, sir.
No, even if it's post-pneumococcal vasculitis, then steroids are warranted
yes, that's
with
what I'm
antibiotic
saying.
cover.
So, but the
And the
neutrophils are so high at this point.
For the edema, it is warranted. Otherwise, the child would die.
Okay.
Well, it's not a wrong treatment. That's what I'm trying to imply.
Okay.
They have done right only. I would also have given it if I would be dealing with the case.
So you would give it as pulse dosage, like how we give an A&E, or like DEXA mostly?
Yeah, I would have given like the first impression which I had when I saw the case was more of an HLH before the infection thing came up. So if it is infection triggered, I would have given a pulse methylprednisolone. But anyways, the dexamethylprednisolone both have excellent anti-inflammatory activity. But I am
Yes.
more comfortable with methylprednisolone with post-pneumococcal. But I have not seen a post-pneumococcal in such a small age still now. So I am agree with
yeah.
the immunodeficiency thing which needs to be ruled out.
Yeah, so actually we DEXA is given as the anti-edema protocol anyways. So this child didn't really improve even after 48, 72 hours. Now is day 10 of illness, and the child is status quo.
Yeah, the sensorium may not improve because the reticular activating system seems to have taken a
Yes.
hit over here.
Yes.
So the coma may not go. Only things we can get as improvement are subject to markers like CRP would come down, ESR would come down. If you do a CSF, then the cells would come down, something like that.
So the child has developed scleroderma at this point. So I think it's a very fulminant pneumococcal infection. Somehow it's resistant to higher antibiotics also.
So even if the child does not make it, make sure to take a sample and send for genetics so that the second child would be prevented.
Sure.
Until
Thank you.
Thank you.
Thank you, sir.
All right. To summarize, we agree that pyogenic infection is most likely caused, but underlying immune or genetic abnormalities to be ruled out. Pancytopenia common, or is it common in the pyogenic infection? Or
I think it just suggests the severity of.
okay. Right. There is a suggestion of HLH, or is it? Sorry, only how to explain pancytopenia. Jayashree asks. Culture sensitivity done. Jayant asks.
I think we're waiting for the report.
Report
I think
is
it's
yet to come.
Yeah, strep pneumonia positive, but the sensitivity pattern is yet to come.
All right. Okay. Yeah, definitely not ANEC in terms of imaging, and yeah, that is the main question. No need for vascular imaging. MRI is done, that's sufficient, I think.
Yes. Yeah.
All right. Thank you. Yeah. Next is also from
Yeah.
Pune.
This is 6-year-old girl, known case of Down syndrome, diagnosed at 3 years of age. Otherwise, she was doing well, and she had 7 days of lower respiratory tract infection, like fever for 3 days, followed by cold and cough. And day of illness 6, there was aggressive increase in cold and cough, and she become bit lethargic, and then the child threw one left focal seizure, and then was she referred to our hospital because of the fall in sensorium. So child was intubated, and the reflexive bricks pupils were constricted and non-reactive, and the child was tachypneic and saturation was 85% on room air, so intubated. During this 5 days of illness, like a child having hypertension unexplained. Like she was having labile blood pressure. So just then we immediately went for an MRI. As
Yeah, MRI demonstrates posterior circulation infarcts on both sides, as you can see out here, involving the thalamus, the paramedian, occipital, temporal lobes, and also the brainstem and the cerebellum on both sides. Yeah, no, these are the main findings. Nothing else on the other conventional sequences. I mean, nothing significant, but yeah, posterior circulation infarcts on both sides. I think I have the video. So, this is the brain angio. I can appreciate the vertebral artery, but the basilar artery are not taking opacified, or there's reduction in flow out there. Those are main findings, I think, are on the neck angio. Going from caudal to cranial, you can appreciate that the vertebral arteries are not taking up any flow on both sides. Going up to the basilar artery. And these are MIP images. Again, there's again some tortuosity of the intercalateral arteries, and also some degree of the MCAs, and the vertebral arteries are not visualized or completely opacified. So posterior circulation stroke out there. I don't have a SAD sequence to see for any CBJ changes. We had only axial images. And there's no neck sequence or T1 fat side neck sequence to see any intramural hematomas. These are the imaging we have, and that was the follow-up investigation done. As mentioned, yeah.
Considering that this is Down syndrome, so like we have ruled out a coagulopathy. Even the EEG 2DK was done to see any cardiac issues, but it came out to be normal with good ejection fraction, and the EEG showed multifocal epileptic discharge is predominantly from the right sided. So only what significant finding was there was dental caries she had. So like, and there was no trauma per se to cause this. So our main question was to see any dissection was there, or maybe because of the atlantoaxial instability causing this kind of a picture.
Okay, so I don't have the SAD sequences to answer the question, but yeah, it looks like bilateral vertebral artery dissection.
Yeah, so I think this child basically had quite significant cough, like lower respiratory tract infection prior to presentation. And I was just thinking, because she already possibly has instability of that joint. And when she was hyperextending her neck, the dynamic movement of the neck, whether it acted like a whiplash, and I don't know whether that might be the reason. She had violent cough, like, prior to presentation.
Yeah, possible, but we'll have to do a CVJ study and just to see any.
Yeah.
Okay, sir. Okay.
She wasn't doing too well. Her EEG progressively worsened over time, so I don't think will be.
Okay.
Yeah.
Anything to add, Anish, on vascular wise, imaging wise? I don't.
No, the only thing, if you could just show me the first diffusion images, I thought I saw a hyperintensity just anterior to the medulla on the left side. Yeah, the second last row, bottom, second last image, bottom.
Yeah, got it.
Yeah, so probably that's a clot.
Yeah.
Yeah, maybe one vertebral artery is hypoplastic and we're not seeing flow signals. So we have one dominant vertebral artery which has got dissected. Cause for dissection, vessels are fragile in any case in Down syndrome, and also there may be a possible atlantoaxial abnormality.
Okay, sir.
Yeah.
Yes.
Thank you.
Thank you, sir.
Just, I mean, next time I would probably include the fat side next sequence and to just see the hematoma in all dissection cases. That is one sequence to be added, I guess.
Sure, sir.
Yeah.
Yeah, or an SWI to
SWI, yeah.
show any strokes, yeah, to show the clot. Yeah.
Yes, sir.
And dynamic only if it's idiopathic and no other causes.
Yeah, but then that can be done later also after the acute stroke, because there's no role in the immediate management.
He might dislodge some more thrombus. That's the problem.
Yeah, not
Yeah,
in the
exactly.
not after immediate stroke. All right. So yeah, question answered. Likely, we'll have to check CVJ sequences for that. All right. With that, I've concluded the new cases. We have two follow-up cases with possible confirmatory diagnosis. First one is from Shida. I think we discussed a couple of weeks back. Shida, you just want to summarize quickly?
Yeah, so this was a case we discussed. 11-year-old male child was being treated like a cerebral palsy elsewhere, but there were no perinatal risk factors. Presented with delay in attainment of milestones, abnormal faces, and poor gain in height as compared to peer group, with progressive gait difficulty and lower limb deformity. So all the basic investigations are non-contributory. So when I considered him like a cerebral palsy mimic, and then imaging was done. Previous imagings are not available. So this is the classical syndromic faces. He had this triangular faces, bilateral alternate divergence squint, and malocclusion of teeth. And in videos, we would see the spastic ataxic gait of spastic diparesis. So because of this, most likely he was labeled. He was also diagnosed with growth hormone deficiency in endocrinology workup and was on growth hormone supplementation also. So yeah, so with this we did a imaging. Imaging wise, we suspected a yeah, Dr. Nihaal can take over.
Yeah, imaging wise, there was neurodegeneration, confirmed white matter changes, abnormalities in the globus pallidi, cerebellar atrophy also, and the corresponding SWS sequences. I think we go on to that. Okay, diffusion did not demonstrate any significant changes in terms of acute abnormalities. Diffusion demonstrated these areas of mineralization in the globus pallidus and in the midbrain cerebral peduncles out there, and overall reduction in brain volume. Spinal cord did not demonstrate any significant findings. So with that, we thought of possibilities of NBIAs, and we had an initial genetic report, which was, I think, not was of uncertain significance. And that time, we primarily thought NBI is one of the possibilities, and also to consider cocaine syndrome. But I think some clinical aspects were missing for cocaine syndrome. Is that right, Sridhar? Or
Yes,
I think
yes.
hearing loss, cataracts, and all that was not there. And
Yeah, so but I was suspecting NBIA
yeah,
mostly Woodhouse
okay,
Sakati syndrome, because
yeah, given
Woodhouse
the
Sakati has this pituitary hypoplasia,
yeah,
and we checked the volume also, which was low for the age. So so only NBIA with white matter abnormalities are either this fatty acid hydroxylase deficiency or this Woodhouse Sakati syndrome. But the imaging showed a pathogenic variant in ERCCB gene, at uncertain significance in ERCCB gene, homozygous, autosomal recessive. Parents are consanguineous, so we'll do a carrier testing. But yeah, I think imaging matches the phenotype.
Have you done a CAT scan? Because
Hello?
cocaine has a high, basically the calcification, right?
yeah,
So
I think that we
it may
discussed
not
last
be
time.
iron, maybe calcium.
Yeah,
That's why.
yeah. I don't think we have a CT here.
Yeah,
Neuropathy.
Photosensitivity, neuropathy is the question. Either the neuropathy?
NPS was showing motor axonal neuropathy. Motor axonal neuropathy.
Okay. No photosensitivity yet, I guess.
No photosensitivity. No, never had this. The cocaine was also considered seeing the faces, but this endocrinopathy, short stature, uh, we thought like iron deposition only. But yeah.
Hearing loss also.
No,
No, hearing
hearing
loss wasn't there. I think that was asked last time. Yeah.
No, it was not there. Hearing loss was not there. Yeah, he
No
has this catectic
cataracts.
progeroid appearance, but this not classical phenotype. Apart even faces in retrospect, if I see, there was no classical bird-like faces which we see in cocaine syndrome. Yeah.
No cataracts, Dr. Namtas, yeah.
No cataracts. No cataracts. No cataracts, no sensory or hearing loss. Neuropathy was more likely because of the muscle mass which was reduced, the CMAPs were reduced, but there was no demyelination in the tested nerves. So yeah, we'll have to test the parents and then we can confirm the diagnosis. But this is what we got. So I thought I'll share with the group.
Yeah. Thanks, Shiva. Yeah.
Yeah, I agree. It's not the classical textbook appearance, but I understand that cocaine syndrome has a broad spectrum, clinically and also genetically.
Yes.
Yeah, agree.
We'll wait for the parental testing and maybe have another final confirmatory diagnosis.
Well, what do you expect from the parental testing? I mean, if these are the parents, they are carriers of that homozygous variant.
Yeah, so if they are carriers, then we can change this variant from uncertain significance to a likely pathogenic variant.
No,
So it
they
will
would
just
be carriers. They would be carriers most of the times, but it doesn't really help because you don't know the functional significance of this mutation.
yeah. So that's what, sir. We can change from VUS to likely pathogenic, but we cannot claim it to be pathogenic.
Likely pathogenic also won't happen, because
Okay.
if you have consanguinity, you can have many homozygous uncertain significance, which has no relevance to the clinical diagnosis. Over here, of course, the biomarker is your clinical picture, your spasticity and your calcification. All that makes it more likely that it's probably cocaine.
Okay. But anyways, we'll have to check parents, sir, as per protocol, or yeah, if they are planning a second kid, we should.
Yeah.
Any experience with endocrinopathy in this group, in cocaine syndrome? Yeah, CT brain, I'll just try to find out. Most likely it was done. I'll try to find the link and share.
But in view of the MR pattern, I mean, there is no doubt that this is abnormal in terms of calcification, no? You don't need a CT to confirm that.
Yeah, I think sufficient enough for Ashida. I mean, if the CT is done, that's fine. But yeah. I mean, abnormal mineralization, white matter changes, atrophy, that would fit into imaging wise of cocaine. So.
Okay. Sure.
Yeah. Okay. Thank you. No experience of endocrinopathy. I think no one has put in. But yeah. Okay. To our last case, and this was done, I think, 3 weeks back or a couple of sessions back. Harika, if you're there.
Yes, sir. So this child is 13-year-old male child, born out of non-consanguineous marriage, no perinatal issues, normal development. He had in January 2025, he had hemiparesis in the form of acute onset progressive walking difficulty, where there was difficulty in wearing and holding chappals, and followed by difficulty in holding objects with left hand. That was progressed up to 3 weeks. And then he was started on steroids. There was improvement in weakness. So this child was treated in other country. And in July 2025, they observed sudden onset drooping of right eyelid for almost 10 days with no diurnal variation and no issue of any fatigability or any further new onset weakness. When we examined, there was right eye ptosis with no fatigable signs and no curtain sign. And there was restriction of eye movements in right eye, elevation of -2 and depression of -1, and right side adduction of -1. Whereas left eye movements were normal. This left hemiparesis, now there is only left pronator rift with mild circumflexion gait and loss of associated movements on left side. So for this thing, because of this new onset right eye ptosis with no diurnal variation and restricted extraocular movements on right eye, child was neuroimaging was done at that time. This CSF analysis was done at the time of hemiparesis, where they have noted WBC of 2 with 2000 RBC, but protein was normal, glucose was normal. At the time, they have done anti-NMDA receptor antibodies that were also negative. They have done ANA profile also, that was negative. ESR was 10. So when they came to us, the child presented to us with right eye ptosis with restricted extraocular movements on right eye. So we have done imaging for that.
Yeah, there's a set of images. I'll quickly go through them. The first one was done in May outside, and there was initial suspicion of FCD. I think we discussed previously. You can appreciate on the flare sequences. If you look at the insular cortex, there is some hyperintensity out there going up superiorly. You can appreciate there's again some focal hyperintensity in the center of semiovale. Yeah, some linear hyperintensity, some focal hyperintensities. possibly bilateral out here, but the predominant changes were in the insular cortex and the basically the capsular white matter and also the centrum semiovale on the right side. Possible focal abnormality out there in the superficial left frontal lobe. I think orbit-wise, I don't have the images, but I don't think anything was mentioned as to be abnormal at that point of time. Yeah, and this was the again follow-up labs done. Everything came out to be negative. Then there's a follow-up scan done a couple of months later. And here you can appreciate there is some areas of hyperintensities involving the superficial frontal lobes and also the parietal lobe out there, the cortex and subcortical regions. The white matter changes remain as what we've seen in the previous study, going up to the deep brain nuclear structures on the right side. You can appreciate that the insular cortex is slightly more edematous on the right side compared to the left. Capsular white matter also demonstrates abnormality. Coming down along the corticospinal tract, there is some hyperintensities going up to the ophthalmic region, and the focal abnormality out here in the dorsal aspect of the pons. In terms of ophthalmic or optic pathway examination or findings, there was no significant edema, no significant enhancement at that point of time. Child had another recent scan a month later. Again, you can appreciate the edematous or the hyperintense changes which was seen on the previous study, possibly slightly less prominent as what we've seen in the previous scan, especially the white matter changes and also the basal ganglia and the capsular white matter changes, but they are still present. The dorsal pons abnormality is still there, very minute, but they're still there. The body of the corpuscle demonstrates some hyperintensity out there. Yeah, so this time we had done a contrast, post-contrast study. You can appreciate there is at least three on the right side in the perivenular region. There is some perivenular enhancement or perivascular enhancement going from the perivenular region to the centrum semiovale. You can also appreciate some punctate areas of enhancement on the last image out here, possibly in the bilateral basal ganglia, or yeah, but more seen on the right basal ganglia, the internal capsule. And these are the SAG and the coronal images. What you can again see these punctate areas of enhancement going along the trajectory of the possible perivascular spaces. With that in mind, I think everything turned out to be negative. NMO, MOG, I think oligocoronal glands also was sent, which is negative. Is that right, Harika?
Yes, sir. Yes, sir. NMO MOG is negative, oligoclonal bands is negative.
Yeah.
And this GFAP antibodies also we have done, sir. Recently we have got that report. That is also negative.
Okay. So yeah, I mean, this is the follow-up scan from the last study. Just a diagnostic dilemma still process. If any other possibilities or any other consultations to be done, or do we treat it as seronegative condition? Yeah, MS was tested. So that was.
MS panel is negative, sir.
Yeah.
Neurobasic HLA typing was also negative. HRCT test was done, which was negative. Both CSF and serum GFAP is negative.
So this was the imaging differentials we thought of. I mean, majority of them: demyelination, GFAP astrocytography, slippers, or a lymphocytic which or MS, everything was tested. So, there are any other inputs?
Any role of biopsy, stereotactic biopsy? That was a discussion ongoing.
Biopsy for neoplasm or?
Yes, sir. The right-sided parietal region with contrast enhancement.
You mean these areas?
Yes, sir.
It doesn't look
That should be
at least. Okay. Imaging wise, I'm not sure. No, cord was never done.
What was the cause of the walking difficulty? I mean, I missed that. I'm sorry, I was disconnected.
Child had a left-sided hemiparesis in Jan 2025, which resolved in.
Okay, hemiparesis. Okay.
Yeah. Then later isolated third nerve palsy. But neuroimaging wise, we couldn't localize the lesion.
Yeah,
We're
the-
just checking in terms of extraaxial.
no, third nerves are normal. At least there is no vascular compression or no edema or no inflammation.
In the system space, or so we have considered. Repeat CSF analysis is also normal.
The question, I think, main question was dilemma was biopsy to be done or not. If
Yes,
anyone
sir.
has,
And still the possibility of MS only, like seronegative ones.
Would a biopsy be absolutely diagnostic, specific, or just inflammatory or whatever?
again, I think they wanted to rule out multifocal glioma or neoplasm for the main cause of biopsy. Is that right, Razi?
Yes, sir. Yes, sir.
As mentioned, the spinal cord MR was not yet done. Perhaps this should
No,
be
sir.
done as a baseline.
Spinal cord is done, sir. It is normal bone.
Okay, it was done initially outside. Yeah, that was normal.
Because this looks very cortical, no? Some of the lesions are cortical.
Yeah, some of them are cortical.
The posterior one, even the anterior right anterior frontal, it's a little swollen over there.
And even the
Mesial
insular
temporal,
cortex.
Mesial temporal also.
All the antibodies are negative. Stuff.
I think it's worth doing a biopsy.
Actually, they left abroad today only. Plan is to repeat an MRI with contrast after 3 months. Meanwhile, we have suggested them if there is worsening in lesions or any new neurological symptoms, we need to go ahead with serotactic biopsy.
At least imaging wise, from July to August, I don't see any significant change. But yeah, I think 3-month interval is good enough to look for progression.
Thanks.
Maybe I have missed a point. Do the lesions explain the ptosis and the ocular problems?
No, sir. Lesions, there is no new lesion which is suggesting the third nerve, isolated third nerve palsy.
CSF for malignant cells is done?
Malignant cytology. No, sir,
That could sometimes, if it's involving the third cranial nerve, you may not see it on MRI, but you may get.
Yeah, we thought of like vasculitis initially, small
The
midbrain.
pupil is reactive or not reactive?
Pupil is reactive, sir.
Then it's probably, probably.
So DADA 2 also was sent, which was negative, and neurobehavior workup was negative.
Okay, I think we'll wait for the interval scan, Razi, before going ahead with the invasive methods.
Sure. But still, like seronegative MS could be a possibility, sir, with normal MRI scanning.
When was it done? It's fine. I think the order was done in May.
Recently only, sir. Like 2 months back. It was done at 10 only.
Got it. I think it was normal, yeah. But if we have a follow-up scan with the new lesions, then that would be activities.
I'm sorry, what do you mean by seronegative MS? There are no antibodies in MS. No? I mean, basically, it's OCB or something.
OCB, yes, sir.
So OCB was negative in this patient.
OCBs were negative, sir.
Even Epstein-Barr was tested, I think.
Yeah, EBV was also negative because last time discussion, MS was considered in NRI. Based on that, we have worked up for that.
So Epstein-Barr is negative, right?
Yes, sir, negative, sir.
Yeah, so almost rules out MS, I think.
MS, yeah.
If I hear your discussion, I'm inclined to be in favor of a biopsy rather sooner than later. This is perhaps still, there are not many points in favor of MS.
Yeah. And despite steroids, there is no improvement in right enough palsy since past 3 months.
Maybe I think this is the frontal and the parietal are more accessible, but we'll have to maybe just get another scan done. Yes. Yeah. Okay.
Thank you.
Thank you.
Thank you. Yeah, I think that's our last case. Yeah, we'll have a couple of weeks break. I think there's some conferences going on for the next cycle, so we'll meet again on the 26th of September. Kindly send in your cases by the printer. And yeah, have a good night and have a good weekend.
Good night.
Till next time. See you. Thank you. Bye-bye. And happy Teachers' Day to all who teach us through their cases and their presentations. Thank you.
Thank you so much.